So for running up to lunch, I'm going to start off talking some very mechanical stuff in terms of drugs and side effects and stepwise approaches to management, and all stuff I'm sure you all know. And then I'm going to move on to something a bit more challenging and a bit more confronting, and hopefully which will echo with everything that's presented this afternoon. And you can kind of reflect back on what I've said this morning. Before I start, I just want to leave a message that you've got to think about why we need to do asthma well. And I think about it as giving the patients the best possible life free from limitation from their asthma. They should be completely free like a bird, with no being able to run around as much as other kids can without having to stop and rest all the time. The other thing is that as we move into school age asthma, everything I'm going to say from now applies to adults, because we can kind of same treatment paradigms, same treatment regimens and same drugs. So that the goals of asthma therapy are to maximise quality of life, which really reduce symptoms, reduce risk of exacerbations and risk of sudden death, avoid adverse treatment effects, so try not to give too much medication, and all of this is done utilising a stepwise approach to management. So the aim, as I said, is to give patients the best possible life free from limitation by their asthma, and the steps for this are assessment and monitoring, getting the patient to take the medications and take them appropriately, active self-management, and reducing environmental triggers. If we do the basics well, we can actually achieve some quite stunning results. This is a paper from a tertiary respiratory clinic in England. So this particular clinic gets referred patients from paediatricians. So the patients have been through their GP, been to the paediatrician, and then they get referred to this difficult asthma clinic. So they had 71 kids over 1 year, and they had a nurse do a home visit. And by doing a home visit, she found a third of kids had ongoing allergens, like privet trees sitting outside their bedroom window or cats sleeping on the bed. 25% of kids were either exposed to smoking or were smoking themselves. 48% of kids weren't taking their medication. There were kids with cupboards full of medication. And 60% of kids had major anxiety or psychosocial issues. So from this clinic, and remembering these kids had been to their GP, been to hospital, been to multiple paediatric clinics before they got referred, only about a half of them actually needed to come to the clinic. And it largely was around the adherence and compliance and the smoke exposure. So just by sticking to the basics, we could actually control a lot of asthma. We have changed the language we use around asthma. So in the past, we used to talk about mild, moderate, and severe asthma, and persistent asthma, and intermittent asthma. And the problem was that if you saw a patient on medication, their level of symptoms changed. So how could you say there was severe asthma when they only had mild symptoms now? So we've changed to talking about control. And this is slightly out of date, but it's the GINA control. And it's really how often they have symptoms. And if you've probably all seen this table before, but what I wanted to emphasize was in primary care, all your patients should be controlled or uncontrolled. Okay? The only people who are allowed to use the partially controlled category are people like me. So this applies to patients who don't respond normally to treatment. So in primary care, your patients are either controlled or not. Okay. And it's basically how often do they have daytime symptoms, twice a week or less? Do they have any limitation in their activity? Do they wake at night with symptoms? Do they use their reliever medication? And for adults, lung function, and how often they have exacerbations. And in adults, but not children, the exacerbations are quite important. So there's quite good British data showing that if you've had an exacerbation in the last 2 years requiring hospitalisation, you're at quite high risk of having another exacerbation. So all those patients, adult patients at least, should be on inhaled steroids, and probably late adolescent kids as well, but not so much the young kids. So assessment and monitoring, and the thing here is actually seeing the patient regularly, which is what I do in my clinic, and which is we need to figure out a way for that to be done in primary care. The aim is no impairment, so completely normal symptoms. And this requires regular ongoing and review. And the first step is to ask about control. And the simplest thing is to ask the asthma control test or something similar. I ask the same questions, but in a slightly different way. And then we want some objective measuring, at least in adults, not so useful in little kids. Reviewing exacerbations and reviewing adherence and inhaler technique. So every time I see an asthma patient, I check their control, I check their compliance, I check their technique, and I check their action plan every single time. And this is the asthma control test, the child version. There's an adult version as well, which has just got 5 questions. But how is your asthma? How much of a problem is asthma? Do you cough? Do you wake at night? And then for the parents, how many days does your child have symptoms? How many days do they wheeze? And how much do they wake up at night? And you add up the score, and if they've got a score above 19, they're well controlled. If it's below 19, they're not. And unfortunately, there's another questionnaire called the Asthma Control Questionnaire, which is the other way around. This one, low scores are bad, and that one, high scores are bad. So you just have to be a bit wary of which questionnaire you're using. But this one's freely available on the internet, and it's quite simple, and your patients can do this in the waiting room while they're waiting for you to finish talking to Mrs. Jones, who won't stop talking about her hip. Asthma medications, I really expect that you are familiar with this, but I'm just going to race through it, but just hit some important points in case there's some gaps. But basically, we're talking about relievers, which is essentially in kids is salbutamol, and preventers and controllers. And I just use the term preventers. I don't talk about controllers at all. This stepwise approach to management is standard throughout the world in terms of asthma management. This particular table is from the BPAC journal from February 2012, which is kind of the closest we've got to a New Zealand asthma guideline at the moment for kids. So step 1, patient only has occasional symptoms, just a short-acting beta agonist. Step 2, add inhaled corticosteroid at a low dose, which would be whether you're using Becotide or fluticasone is going to be 1 puff twice daily. Increase that to a moderate dose, which is 2 puffs twice daily, and then add a LABA. Step 4, increase your inhaled steroids to a high dose and add an oral medication, which might be steroids, or it might be montelukast, or very rare cases, it might be theophylline. At this stage, you really need to be thinking, does this child really have asthma? And you really need to be thinking about referring for assessment for specialist tests, because almost all asthmatics will actually respond to a low dose inhaled steroid. Once they're on frequent or continuous oral steroids, they definitely need to be referred to a paediatrician, partly because anyone on continuous oral steroids is at risk of Addisonian crises and growth problems, and they need to be monitored, but also because it's very likely this patient doesn't have asthma, and they need a lot of testing to figure out what's the underlying problem. So relievers, short-term bronchodilators, these drugs work on the smooth muscle surrounding the airways and relax it. Beta agonists, so salbutamol, or in the turbuhaler, we've got the terbutaline, and then we've got the anticholinergic. So don't forget there is Atrovent out there in terms of adding another medication. Theophylline, almost never used in kids, and because these drugs come in IV forms as well, we use IV magnesium sulfate as a bronchodilator in the hospital, so you'll see that in discharge summaries. These drugs tend to have a short onset of action and then a short half-life and short offset of action, so salbutamol lasts for about 2 to 4 hours. In general, using a spacer is better than a nebulizer. So in trials, it's equally effective. You get the same amount of drug into the lungs because nebulizers waste a lot, sprayed around the room. But also because nebulizers spraying into the eyes and the nose and the mouth, you get a lot more systemic effects with tachycardia and jitteriness with a nebulizer. So it's preferable to use a spacer, also much cheaper and more portable. And as I said, we can use these drugs IV. And the adverse effects are pretty much the same: tachycardia, jitteriness, and if you really give someone a huge dose, seizures. And theophylline's by far the worst, which is why we try and avoid it. There's quite a high rate of side effects from theophylline in children. Preventers, the old mast cell stabilizers, there's really no evidence of benefit in children from Intel, but it's still on the market. And then inhaled corticosteroids would be by far the most common preventer used. Then we can add a long-acting beta agonist, or we can substitute a anti-leukotriene antagonist. Inhaled corticosteroids suppress inflammation, so they're acting on that background continuous inflammation that's going on. And that's, when you're talking about asthma education with patients, it's very important to remind them it is, it's an inflammatory disease and there's inflammation in the airways all the time, and that's why you need to take your inhaler all the time. They have a long-term effect, so it's no good using it now and again. Reduces regular symptoms and reduces exacerbations. Well proven in adults that inhaled corticosteroids prevent exacerbations, not so well proven in kids. And I think it's because of that crossover from preschool to school age. There's not a magic line in the sand at 5 years of age. It's just sometimes kids get such an inflammatory surge from their virus that you just can't stop them having a bad exacerbation. Most of the benefit is at low to medium dose. So this is beclomethasone, 2 puffs a day is here, just before you hit the flat part of the curve. So you don't, as you go up to high doses, you're not getting much increasing benefit. So really we want to stick to low, we want to start with low doses and then go to medium doses and then probably add another drug before we go to high doses, because we're not going to get much benefit and we're going to get more side effects from going to high doses of inhaled steroids. And it's important the patient has really good technique with their inhaler, because if they've got poor technique, all the drug's going to go in the back of the mouth and they're going to systemically absorb it and they're going to get side effects without any benefit. Adverse effects, oral or pharyngeal thrush, hoarse voice and cough, not necessarily from thrush. You can get a funny cough from Flixotide, just from funny effects on the vocal cords, and that can go away just by changing the brand of medication. Something that adults don't get is kids get growth suppression, particularly if they're on very high doses. And then things that kids get more often than adults, if on high doses, HPA axis suppression, so they become at risk of Addisonian problems, osteopenia, skin thinning, and so I've left out cataracts there. Kids are more likely to get cataracts than adults with chronic steroid use. So all of that is why the recommended doses for children for inhaled steroids are lower in kids than in adults. And if you look at your special authority criteria for adding LABAs, they're lower. Your ICS dose is lower in kids than in adults.
So how quickly would you increase up an ICS dose in a child?
Probably in a month when I first see them. But I see most of my patients every 3 months, so I'd probably bump it up then. Having said all of that, being on a high dose inhaled steroid is probably better than being on prednisone. So that's the trade-off. I just wanted to go over the dose equivalencies, because there's new drugs on the market and it's going to get really confusing. So the standard is the old Becotide, which isn't really available in New Zealand, I don't think, or budesonide, which is in the Turbuhaler. Then we've got the double strength drugs, which is Flixotide, and the new ultrafine beclomethasone, so that you give half as much of the drug because it's twice as strong. And also ciclesonide, which you probably haven't prescribed. And then the brand new ones are kind of quadruple strength. These are going to be the new once daily drugs, the Brio, Ellipta and stuff. So they're the ones that are going to really confuse people. So it's just important to remember it's 4 times and not to overdose your patients. LABAs, most common one used in New Zealand I think is salmeterol, which comes in the nice purple puffer, but also ephemoterol. These drugs are different, so you'll all be aware of the Smart Pro, I'll come to that. And then also we've got these new once daily long-acting beta agonists coming as well. These are, I think they're licensed for COPD at the minute, but they'll probably become licensed for asthma in the future as well. There is a dangerous class effect, which is increased severe exacerbations and increased death with the use of LABAs. So that is why if a patient doesn't respond to adding a LABA to their inhaled steroid, you stop it. You don't just leave them on it and add more medication. Also, untested in children under 4, so not to be prescribed in that group. I've seen kids on it who are under 4 and it works, but it's because it hasn't been in any trials in that age group, I just wouldn't prescribe it at all. Ethamoterol has the advantage that when we're prescribing it, it's on the steep part of the dose response curve. So as you give more doses, you get more effect. You don't get that with Seretide. It's on the flat part of the dose response curve, so there's no benefit to increasing the dose. Also, salmeterol takes about half an hour to work, and ethamoterol takes about 5 minutes to work. So for those two reasons, you can use your Symbicort, the red one, Turbuhaler, as kind of a PRN dosing in this kind of smart regimen. So you have some regular medication, and then when you're a bit wheezy, you have some extra of your preventer. And that has the advantage, which I'm sure you all know about, is getting an extra dose of your inhaled steroids to suppress the extra inflammation as well. Not well proven in children, that strategy, and because of this concern about sudden death, we're not very keen on it in kids. But I think the adult respiratory physicians are very keen on it. And I've had some success with it. It's really good in patients who are non-compliant, who just kind of need a different way of looking at their medication and a different kind of incentive to become compliant. So it kind of just changes their way of viewing their asthma. I'm not sure it's actually any more effective. In the future, there are new treatments coming online. So right now, if I'd given this talk 2 years ago, I would have been saying, I have no extra treatments than you to give to asthma. So my job solely is to make sure this really is asthma. And then I discharge the patient because I can't do anything more. But there are new drugs now. You'll be familiar with the long-acting muscarinic antagonists that have just come out for COPD, or Spiriva's been out for quite a while. Those are being licensed overseas for asthma, and they will inevitably become funded and licensed in New Zealand for asthma. That's off in the future, not now. And then we do have one drug, omalizumab, which is an injected subcut injection given fortnightly or monthly. It's a special authority, has to be prescribed by a respiratory specialist. But just if you've got to the point where you've stopped referring asthmatics to respiratory specialists because they can't do anything more, actually now we can. So you can start referring these difficult asthmatics if you think they'll benefit from omalizumab. So we've talked about assessment and monitoring, and now we're talking about giving medications appropriately, and we have to give the right device. And the most important thing with the device is the patient needs to be able to use it. So for young infants, we can give a spacer with a mask because it requires almost no, they just have to stay still. If you've got really young kids, I just leave a spacer in their toy box and they'll play with it and they'll get kind of desensitized to it. My kids think it's a trumpet. Once they're older, we take the mask off. This means a patient has to be able to form a good seal. They should be able to do this around 4 years of age. Some kids can do it younger. Some older kids can't do it. So you do need to test that they can do it. But it is important because you get about 2/3 more drug into the lungs just by taking the mask off. So that's one of the first things I do when I see a poorly controlled asthmatic is get rid of the mask that they've been using. However, when they're really, really sick, they're going to need the mask again because they're going to be struggling to breathe. Also, with the mask, you can give it in sleep. Turbuhalers, I think I've mistyped that. Very difficult to use. We hardly use it in kids, largely because we meet kids when they're preschoolers. We start them with a spacer, and they just continue with the spacer. But kids from about 7 or 8 years should be able to use turbuhalers. Although towards lunchtime we'll talk about whether that's really the case or not. So 7 years at the earliest for the use of a turbuhaler. MDI on alone, absolutely never. Children just can't coordinate it, and to be honest, most adults can't either. Although it's quite convenient. But with the, I don't know if you should have all seen the new spacers. You can just peel this off and store your MDI inside there. These are newly funded spacers, so it's quite a small, convenient package to take to school. So I don't think there's much difference from taking MDI. So that's the ideal. But unfortunately, in New Zealand, only 80% of children under 6 use a spacer. 20% of kids under 6 are not using a spacer. So getting drug that's just going in their mouth and not into their lungs. Only 30% of children over 7 use a spacer. So again, most of those kids just spraying into their mouth, hardly any drug getting into their lungs. Lots of side effects, no benefit. Less than 35% given an action plan, which is really bad. Sue Kringle again. So, really important, you don't really just prescribe an inhaler. You have to teach the patient how to use it, and you have to see them use it. They have to demonstrate the technique in front of you, and I'll come back to that just before lunch. Okay, so practice points. Treatment should be started at the lowest step consistent with the patient's symptoms, which should be step 1 or 2. Often people want to start with 2 puffs twice daily of the inhaled steroid. It really should be 1 puff twice daily. Most people respond to that. We've given up using the word severity. We use control more because your assessment will change once they're on treatment if it works. Reassess every 2 to 3 months and step up or down, and titrate to the lowest step that controls symptoms. So I was talking to a few people in the break. If the patient's got no symptoms in summer, then you can take them off their inhaled steroid. But only 30 to 50% of asthma patients are well controlled. So most asthmatics out there are poorly controlled. And that's the same in New Zealand. Compliance with inhaled corticosteroids is only 20 to 30%. And that's probably the biggest issue in asthma, is getting people to take their inhalers. 34% of patients with uncontrolled asthma use a preventer less than 1 per week. So even the most severe patients are not taking their inhalers. So this is a worldwide study. This is the Asia Pacific region, so it includes New Zealand. And you can see across all the categories, these are the patients using a reliever, and these are the patients using steroids, inhaled steroids. This is appropriate. This is not. The number of patients not using an inhaled corticosteroid is the same across all severities. This is not the same as prescribed. This is using, but it's still a big issue. Most people with severe, poorly controlled asthma are not taking a regular preventer. And it's important. So this is a paper on compliance. If you're more than 80% compliance, then most people are well controlled. If you're less than 50% compliant, most people are not well controlled. And these people are at risk of severe exacerbations and death. So this is important. So this is 2 papers from the same group, one old, one relatively new. Oh, that's old now too, but it used to be new. So the more inhaled steroid canisters you're prescribed per year, so this is UK data, so every month you have to go to your doctor to get a new prescription for your one canister. The more canisters you get per year, everyone should be on 12 per year, the lower your risk of death. Likewise, the more salbutamol you use per month, the higher your risk of death. And the concern is these people are the same people as these people. You know, they're going to they're contacting their GP, getting sent a prescription for salbutamol, but not getting sent a prescription for inhaled corticosteroid. And the concern for me is that that's all on the computer now, and people aren't noticing that they're recurrently prescribing salbutamol and not prescribing Flixtide.
Or they've got 3 inhalers and they don't know which one to use.
Yeah. So this is a new slide, it's not in your handout. Assessing adherence, how are we going to do that? Particularly some of the PHARMAC requirements are that you have to have proven compliance. It says that for the omalizumab, but there's no way of doing that. So the simple thing is your prescribing records. What does MedTech tell you about what you've been prescribing? We have access to this in the hospital. I don't know if you guys do, but I can look, when I see a patient with asthma, before I see them, I look up their prescribing data. So I see what drugs have been prescribed, and I can just check that they've gone to the pharmacy at least every 3 months to pick up a prescription.
When you say you can check what we've prescribed, you check what we've prescribed or what they've actually...
No, this is what's actually been dispensed. So it's from the pharmacy. And I think there's a move to try and get all that information available. Self-report, I think what I ask patients first is how often you're supposed to be taking your inhaler. Should be 2 puffs twice daily, or 1 puff, and surprisingly often they're very confused, so it's actually quite important to ask what you should be on. And then I ask, how often do you forget to take that in a usual week? Not how often do you take that, but how often do you forget? Because people are much more honest if you ask them how often they forget. You can also, there's some other questions you can ask, like when you feel well, do you stop using your inhaler? Or when you get worse, do you stop using your inhaler? But I just stick to those 2 questions. apparently doctors can tell magically whether people are compliant or not. The best is to have an electronic monitoring device. So there's the little inhalers where you, each time the patient dispenses it, it records how many presses and when they took it. And the when is really important. So there's a really nice randomized trial where they didn't tell the patients they had this device, and they came into clinic, and in the elevator people were hurriedly discharging their inhalers. So that's really the only objective way we've got. Of course, that doesn't tell you whether the patient actually inhaled the medication or whether they inhaled it correctly. Action plans are really important. So in adults, it's proven in randomized trials that adding an action plan prevents hospitalizations and ICU admissions. So it's actually, standard evidence-based medicine. In kids, educational packages that include asthma action plans improve hospitalizations. The aim is to help patients and caregivers to maintain their asthma and what to do in an emergency and when to seek help. And I think when we're talking about a disease that kills people, that's really important. The most important section is when and how to seek help. That's what I spend most of my time going over. But the other bit is right at the start is even when you're well, you have to take your preventer twice a day. And I spend quite a lot of time telling people to call an ambulance because we have had children die in the back of the car on their way to hospital. And if you're stuck in traffic, then you can't be in the back seat helping your child. So it's better, even if you have to wait 20 minutes for the ambulance, it's better to wait so that somebody is looking after the child. These are some action plans. I think we'll be looking at some of these this afternoon. This is the Pictorial Asthma Action Plan. Pictorial Asthma Management Plan. That's the website. Nice, simple one. There's a study in Pacific Island patients showing they like this. And this is the Standard Asthma Foundation of New Zealand one. We've got our own one, which is not very good, but we use a different one in a hospital. But you can, and we'll be talking about other sorts of action plans this afternoon. Other things to consider, smoking cessation. I always raise smoking as an issue. I don't want to scare off patients or antagonize them, so I don't say you have to stop smoking, but I'm trying to make a joke of it or something, assuming that other people have tried to address this before, but it is important to raise it and continuously raise it. Allergen avoidance, I have to say I do very little allergy testing. Because I kind of think that allergens are all around and you can't avoid them. But occasionally you get someone who's got a privet tree in their garden or a cat or a dog that they're profoundly allergic to. Dogs especially worth testing for because most people are not allergic to their dog, but some people will be. And it's, in all the asthma guidelines, they may all make a big deal of allergen testing and allergen avoidance. And then associated conditions. Does the patient have hay fever making their asthma worse? Do they have reflux making their asthma worse? Do they have OSA making their asthma worse? So this is my approach to asthma. So I come in here and I work up and I address these 4 points. But in primary care, I guess I would expect that you guys would do the same, but start at the top and work down. So first step, poorly controlled patient, they're probably not taking their inhaler. So that's the first thing to address. Second, they're taking their inhaler, but they're not doing a very good job. Third, have they got something else making their asthma worse? And lastly, is it not asthma at all? And these last two groups, they probably need to be referred to a paediatrician for testing like sweat tests, immune function tests, bronchoscopies, CT scans. And in New Zealand, the big thing we need to watch out for is bronchiectasis. So I haven't put it in any of these slides, well I have actually, but you really need to ask if patients have a chronic or wet sounding cough. Because there's a lot of people with bronchiectasis who've been misdiagnosed as asthma. Okay.
Can I just ask on that note, how often do you see bronchiectasis in children? I've never seen it, to be honest.
Well, the bad news is you have.
Yeah, okay. And I haven't knowingly missed it.
Yeah, you've probably seen quite a lot. So New Zealand has at least 10 times the rate of bronchiectasis as the UK and the States. So we've got a lot of bronchiectasis. I think our bronchiectasis clinic in Auckland is twice as big as our CF clinic. And there's, the healthy lung study keeps coming up, and my interpretation of the healthy lung study, these are kids who've had severe exacerbations of bronchiolitis going to hospital, and then we're following them up, and then we're doing a CT scan, and a lot of those kids are coming up with bronchiectasis. And the problem, I think there's just a huge amount of bronchiectasis in New Zealand through all ethnic groups, but particularly in Pacific Island and Maori, that we're just simply not diagnosing. And we're calling a lot of it bronchiolitis, and we're calling a lot of it asthma.
I think that,
And the treatment's different, so it's quite important.
I think that's what came up, David, that we were finding it earlier. That's the good
Yeah, yeah. So the problem with the healthy lungs study is that the treated group got CT scans and the control group didn't. So unsurprisingly, we found a huge amount of bronchiectasis in the treated group. And now we've suddenly got to figure out what to do with the untreated group, because there's probably a lot of bronchiectasis there we haven't picked up.
Have you got an opinion of the small particle preventer versus the traditional methods?
I do.
What would that be?
I suspect that in 10 years' time, we will be recommending small particles. Right now, there's not evidence to say there's a difference. I think particularly in preschool wheeze, because so asthma and airways disease start in the small airways. So I suspect, my big suspicion is in 10 years' time, and particularly in preschoolers, will be strongly recommending small particle inhalers. But right now, it's all theory, and in practice, the trials we've got show that they're equivalent. And any benefit from using them is just theory. But yeah, I think they're probably better.
We're certainly finding anecdotally in adults that people who don't respond to traditional serotypes and so forth, some of them are definitely responding to acute.
Yeah. And I think, it kind of comes back to the whole lung function. I've said that kids with asthma have normal lung function. That's because it's kind of measuring the larger airways, and I think, if we could measure the smaller airways better, we would find benefit from the small particles. And we'd find more abnormal lung function if we could measure it better. But we can't, so it's unproven.
When you say that LABAs, prescribing a LABA is highly associated with increased hospital admissions and death, is that referring to the research prescribing LABA plus a SABA in the absence of a corticosteroid, or is it with? The
data is really confusing, because when it was first published, people said it was in the group who didn't get the inhaled steroid. That's not true. So it occurs in people who get inhaled steroids as well. It occurs in all the drugs. It's not just salmeterol. So you do, I think when you prescribe a LABA, you just have to warn patients, if your asthma gets more poorly controlled from this, you need to stop this drug. And the other thing is, if a patient, don't start LABA when patient's poorly unstable, which means don't start it in hospital, I think. I always stop the LABA when they come into hospital.
What's the pathophysiology then? What happens?
I think, there's a few theories. I don't think we really know. One of the things is when you bind a beta receptor, you downregulate them. So theoretically, if you've got getting lots of LABA, they're always bound, and so you've got less beta receptors. So you can't respond to the salbutamol when you need it. So that's one theory. Another theory is that it's actually genetic. Some people have polymorphisms in different receptors, and they just respond paradoxically to the LABAs. The other thing to remember is that slide of patients having lots of salbutamol. If you have too much salbutamol, your airways get irritable and more prone to bronchospasm. So it may be just irritability of the airways. There's a good meaningless word.
You don't do much talk about allergy avoidance. I work in an allergy clinic, and the biggies are house dust mite and grass. You don't sort of talk about immunotherapy for those patients at all, or
no. So I have a bit of interaction with the immunology clinic because they want their patients who have anaphylaxis to food. If they've got poorly controlled asthma, they're more likely to have sudden death. So we try and get their asthma under really good control. My issue is you can't avoid grass, and you can't avoid house dust mite, and there have been massive studies where they've tried to reduce house dust mite exposure, and they've had some benefit for about 6 months, and then the benefits disappeared. I think when sublingual immunotherapy becomes widely available, it'll be great.
The grass at the moment is
Um,
coming through for house dust mite.
Yeah. So, the difficulty is people who have multiple allergens. You know, if you want house dust mite and grass, it's not clear what to do. It's been quite expensive. You know, people had to kind of import it themselves and stuff.
But I guess it's that long-term effect that you can avoid the allergy, but if you've got actually something that you switch off the allergy, the long-term benefits, you know, if you've got the asthma poorly controlled and you've got this house dust mite allergy, if you've got a long-term effect, surely the cost would outweigh that, you know?
Well, yes, but the treatment's really expensive. So you have to have a low number needed to treat, and the treatment's really intensive and impractical. You know, it's multiple visits over 2 years.
But the tablet itself, you know, it's a home thing, so you don't actually have to come into a clinic monthly or weekly like the cuts. So, you know, it is.
Yeah, well, having seen my patient's asthma compliance, I'm not sure how well home sublingual immunotherapy is going to work. Yeah. Cool. Yeah, but if there was good, if there was freely available immunotherapy rather than good, then that would change my opinion. But it's been difficult.
Future, that's we're just starting.
Yeah.
In New Zealand.
Yeah.